Hi, everyone. This is Lucas Voss with Becker's Healthcare. Thanks so much for joining us for today's conversation on how reactive insulin protocols are exposing hospitals to potentially avoidable CMS and quality risk. Before we begin, I'll walk us through a few quick housekeeping instructions here. If you have any questions for our speakers throughout the webinar, please feel free to type them into that Q&A box you see on your screen. We can follow up to get you an answer there. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that same recording. If you have any technical issues, audio or visual, just try refreshing your browser first. That generally helps. You can also submit any technical questions into that Q&A box. We're certainly here to help you. And with that, we have such a fantastic group of panelists here for our discussion today. I do want to kick us off with introductions for those that might not know you yet, at least. Dr. Paul, I think I'll kick it off with you. You start us off.
Great. Thank you so much. It's really a privilege to be here with all of you today. I'm Harpreet Paul. I'm the Chief Medical Officer at Jersey Shore University Medical Center and K. Hovnanian Children's Hospital. We're part of Hackensack Meridian Health, and we are a large referral hospital for the network located in the central and the southern region of New Jersey.
Thank you so much for being here. It's great to have you. And we'll stay on the East Coast. Dr. Marshall, over to you.
All right. Good afternoon, everybody. It's afternoon here. My name is Louis Marshall. I am currently the CMO at Health and Hospitals Lincoln Hospital in the sunny South Bronx. And throughout my experience in healthcare, I've experienced in everything from pre-hospital care, emergency management, emergency department, inpatient, as well as ambulatory care. And I'm happy to be here with all of these distinguished speakers to talk about this subject.
It's great to have you. Thanks for being here. Dr. Slovis, over to you.
Hi, thanks for having me. My name is Ben Slovis. I'm an emergency physician by training and board certified informaticist here at Temple Health in North Philadelphia. We're a 6 hospital system serving some of the larger underserved populations of the Philadelphia area.
It's great to have you. Last, but certainly not least, Dr. Chittister, over to you.
Yes, good afternoon. Also from the East Coast, it looks like we're all from the East Coast. Dr. Paul Chittister, I'm the medical director for EndoTool, which is a product of Glooko. My clinical background is that of a nephrologist, and then I moved into the darker side with hospital administration, where I actually with Centera Healthcare, where I was the chief medical officer, and there I led the implementation of insulin dosing software across the 12 hospital system. And I've been now with EndoTool and Glooko for 5.5 years, and really happy to share some insights with our product with you all today, as well as how that dovetails with the CMS metrics.
Yeah, it's great to have you. Thank you so much. Fantastic insights there. And yes, a completely Eastern Conference, as I say, as a sports fan, panel here today. I want to sort of level set us all for our conversation here today. We know that a lot of hospitals still rely on sliding scale insulin, static order sets, or even, unit specific policies depending on where you're at. I'd love to know, where do these approaches fall short when organizations are held accountable for these system-wide outcomes and reportable events as well? Dr. Slovis, I'll kick it off with you on this one.
Well, I think here at Temple, we're in an interesting position. We are currently leveraging the product that Paul works for, EndoTool, at our organization now system-wide. And, from the standpoint of how sliding scale traditionally worked for our health system, I think of it as being a little bit more reactive than predictive. So leveraging a process instead where we can control for variability in the individual patient in order to allow for tighter glycemic control is really going to, I think, allow our system to comply with these quality measures. And, I will say that obviously it's nice when we are able to comply with quality measures, but it's really about patient care. And ultimately, we are very invested in making sure that our patients' glycemic control is tight because it's better for patient care, it's better for their overall healing process.
Yeah, and with more control, again, you also have more control over that patient care. You're able to care better for the patient with that control. Dr. Paul, same question for you as well here. How are you seeing this? Where do some of these traditional approaches fall short for organizations?
Yeah, thanks so much. So definitely want to add to what Dr. Slovis just mentioned that, historically you've got the challenge that you've got multiple different disciplines that are working on this, and sometimes it's challenging for one system to bring all of this together so that the teams have the uh, real-time visibility into this, so that it's not so much a reactive process, but a real, allows the teams to be predictive about which patients are at highest risk. So I think that's really the challenge that we're dealing with. And also there's variation across providers as well. So that variability is definitely a challenge as well.
Yeah. Dr. Marshall, same thing for you. I'm assuming the control piece is important as well, but how are you seeing this?
Yeah, I think it sounds like we're all on the same page. It's really about patient care and preventing, episodes of hypo and hyperglycemia, because we do know that, especially with hypoglycemia, that it can be life-threatening. It can prolong hospital stay and increase the cost of care. So looking at how we work to comply with monitoring will help us improve the care that we're providing to our patients. And I think that as we move forward, and as Dr. Paul and Dr. Slovas have said, being more predictive rather than reactive, I think is going to be critical for us.
Is that something you're currently focused on as well, is creating more of those processes to be able to be more proactive?
Yeah, we've put in several performance improvement processes, and we're looking at, how we're monitoring our patients with diabetes from the time they arrive in the emergency department, and even pre-hospitally, right? Because even in a pre-hospital setting, we're concerned with patients with diabetics with hypoglycemia, and then once they come to us, how do we predict which patients may or may not develop hyper or hypoglycemia, and what types of tools do we have available to us, and especially predictive analytics, I think will be very helpful. We also think about continuous glucose monitoring and how that might be a benefit in this group of patients, in the hospital, in hospitalized patients. So we're looking at all those. Our current uh, goal is to reduce our hypoglycemic events from 3.6% in our diabetics to 2%. So I think that's an aggressive goal, but I think we'll get there.
I'm sure you will. Dr. Shadester, I'd love to again tap on your experience here too. Are organizations aware of this? How are they approaching it when you're having conversations with them? And again, where do some of these approaches that you're seeing still being used today fall short?
Well, clearly, I think that the word for today is proactive versus reactive, and knowing that sliding scale is so reactive, it really falls short of what we need to do. I think there is a concept of meeting the variation that occurs within patients, and a one size does not fit all. But what's even more surprising is a lot of hospitals, as they're beginning to start on this journey, they really do not even know what their performance is. It's encouraging to hear the speakers on this call today talk about they're aware of what their performance is, their rate of hypoglycemia, the rate of severe hyperglycemia. But we find a lot of clients are not even aware of that, and that's a really big first step. Again, in this case, you probably need to be a little bit reactive. Find out where you're falling short in your performance, and then react and institute proactive measures to drive better performance.
Now, that proactivity that you just mentioned, I just wanted to touch on that really quickly, becomes even more important, I'm assuming, with again that mandatory reporting period for CMS glycemic metrics beginning in January 2026. Has that increased awareness for organizations to be more proactive with that requirement and that reporting period now being there?
We're certainly getting a lot of interest from organizations as how can we help to improve their outcomes. Some are just appalled at what they're finding out with their outcomes. Some are still just really just trying to figure out how they're going to determine what their outcomes are. But yeah, clearly there's a much bigger interest, and we're seeing a much bigger interest in our products traditionally have focused a lot on treating patients on insulin infusions, but now with a product for sub-Q insulin, we're seeing a lot more interest in institutions wanting to improve their outcomes for patients on the regular nursing floors, not just in the critical care units using IV insulin.
Yeah. Speaking of, again, those CMS reporting, mandatory reporting requirements, et cetera, again, we talk about the requirement for severe hypo and hyperglycemic events right now. Dr. Paul, what limitations of traditional insulin protocols have become most apparent, especially those that may have been acceptable in the past, right? We now have those requirements that are there now, and which are the ones that are no longer sufficient today.
Thanks so much for that question. I think with all the complexity that we're seeing right now, and with um, the multidisciplinary approach, I think the what's most apparent to me is for some of these conditions having those right pathways, that clinical care pathway in place. And through that work, it's becoming obvious to us that, some of the older standards for monitoring are no longer applicable for some of the conditions and the complexity that we're seeing. So that's an example of, where I think the focus needs to be.
Yeah. Dr. Marshall, you mentioned your aggressive goal. I'm certain that you are also looking at it from a mandatory reporting perspective, and again, CMS guidelines, et cetera, being in place there. What limitations of those traditional protocols have become most apparent as we're going through this process? Again, some were acceptable in the past, some might not be anymore. Where are you at on this?
So I think, as we all probably realize, sliding scale is ancient and historic and very reactive, and that's how I think most of us are monitoring our patients with diabetes in the hospital at this point. And I think that that is something that we will need to get away from. That proposes a lot of limitations. It takes staff time, equipment. Everything's got to be working well. Employees need to be reminded to do the testing, so you need, alerts within your electronic health record system. So there are a lot of pieces in play, but they're all reactive, right? None of them are proactive. So I think that those are some of the limitations that we've seen, and trying to work solutions for them.
Dr. Slovis, I saw you smiling there, especially on the comment regarding the ancient sliding scale. I'd love to get your perspective on this as well, in terms of what's happening with the required reporting, and again, what some of those traditional limitations are that have become most apparent as we're going through this process.
Well, I think just like any other process within healthcare or anywhere, you always have to look at it with an assessment for an opportunity for improvement. We can call the sliding scale antiquated. It probably is, but instead think about ways that we can leverage technology today to improve the process. We have predictive models for so many other things. I believe it was Dr. Marshall who mentioned predictive models. So, thinking about how we can leverage technology to improve something as what appears to be so simple as glycemic control and dosing of insulin in the hospital, to allow for us to better care for our patients. In many ways, while we're all now being asked to evaluate for the purposes of quality, it's a great opportunity to look at something that's considered to be relatively simple on a day-to-day basis, and really reflect on the opportunity for improvement and leveraging tools in 2026 to manage patients' glycemic control.
Yeah. Dr. Schiedesser, I'm assuming you've seen this process firsthand as well. And again, from your perspective too, what are some of those limitations that have become essentially most apparent, that there are limitations for organizations right now, and they are simply no longer sufficient?
I think a lot of it has to do with the complexity of the patients that are cared for in the hospital today. And over 30% of the patients in a hospital at any given time are receiving insulin therapy. From some viewpoints, it can be a real commonality that, oh, there's just diabetics here. It's white noise. We have a lot more other important things to take care of. Why is it so important to just streamline their care while in the hospital? They're going to go back to their old ways when they're discharged from the hospital. But we really need to take a viewpoint of, dysglycemia is no longer a sort of a rite of passage of being in the hospital. Just like in the days we used to think that ventilator-associated pneumonia or central line bloodstream infections were something that just were a byproduct of being in the ICU. We no longer think of it that way. These are events that we almost completely eliminate from the hospital scene. We need to take the same approach with glycemic management. That good glycemic management is essential for the care of the patients, and not having it just be a piece of white noise with other medical problems the patient has, but something that we really need to put at the forefront and give it the attention that it deserves. Giving it that attention will then really take outcomes to where they need to be.
Now, as a follow-up for you here too, again, these guidelines generally have a good intent when we speak about CMS and we speak about mandatory reporting requirements, etc. From a leadership perspective, though, where do you think are the biggest gaps between, again, that guideline intent and the bedside execution that you're seeing from organizations right now?
One thing I think that's really a little bit short-sighted on CMS's approach to this is that they're looking at the number of admissions with a hypoglycemic event or a hyperglycemic event. So that you have an admission and there's one hypoglycemic event, there can be three or four more on that patient, but that doesn't really count to the detriment of your reporting. It certainly is to the detriment of the patient, but it's not to the detriment of the reporting. So that's an area where I think we fall short. There's some other aspects though within the metrics that I think that show some good common sense. The patient that comes into the hospital in hyperglycemic crises with a glucose greater than 1,000, they're not going to be counted in that index of patients for hyperglycemia. And again, they're only looking at patients that have a diagnosis of diabetes and are being administered hypoglycemic agents. So it really does tend to focus down on the patients. It's not going to affect the patient that happens to have liver failure and severe hypoglycemia. So in some ways they fall short. In other ways they make a lot of sense for what we should be looking at. And they also really strive to be monitoring glucose more regularly, because if you skip a blood glucose measurement one day and the two glucose measurements the days before were in the low 200s, that's going to count against you. So you really want to be checking the glucoses every day.
Yeah. Dr. Marshall, I'd love to open this up for the panel as well here. Again, where are you seeing those biggest gaps between the guidelines that we have now and that bedside execution?
I think the gaps that I'm seeing are really about making sure that we are measuring it, right? The glucose on a daily basis so that the patients are better off, right? I think that some of the barriers that we've seen here are, and I mentioned it, lack of, best practice advisories within your EHR, not enough glucometers on the unit, broken equipment, gaps in staff training on insulin protocols, I think is another area that we need to take a look at. And that's where we're concentrating on those areas right now to try to help reduce some of our hyper and hypoglycemic episodes.
Yeah, it's multidimensional. You mentioned staffing, equipment, et cetera. There's so many different aspects to this. Dr. Slovis, same question for you. I'm assuming you're seeing similar gaps.
I think that the major gaps are just kind of in the translation of the metrics. The measures I agree with Dr. Chittister are, like, generally speaking, are intended for good. But they're written in the sense of ideal conditions, and sometimes it's hard to translate that to the bedside. For me personally, I think what's interesting is that there's chronological elements to these measures where good intention to respond appropriately to glycemic control and to alerts and values. If they're not met within the perfect timeline, you have a fallout. Well, obviously we have to have specifics for the measurements. It leaves us focusing in many ways on timing as opposed to on the patient.
Yeah. And I'm assuming that perfect timeline doesn't always exist, as the name suggests. Dr. Paul, same question for you here as well. Specifically, when we talk about the bedside execution piece of this, what are these gaps specifically for you and your organization?
Yeah, and I definitely wanted to, I agree with Dr. Slovis and Marshall. There's a couple of main areas. So one is the multidisciplinary collaboration and who is the owner of some of these results. So making sure that there's a really coordinated approach to some of this data and knowing who's going to be acting on that data as well is really important. The standardized protocols, as we've already been discussing, those care pathways is really, really important. And that real-time data visibility, like we've already discussed as well. So those are the core themes that our teams are working on right now.
I would just like to comment too. You mentioned that the standardized protocols. We need to also not want to over standardize as well,
Yeah.
because the variation that occurs within patients, you need to be able to account for patients with kidney insufficiency, your greatest risk for hypoglycemia, patients that have been treated with steroids, risk for hyperglycemia, or if they're insulin naive and they've been started on steroids, there you worry there that you may overtreat them. So it's really need to be taken into account of all the variations that are occurring in each patient,
Yeah,
from
definitely.
not just each patient from day to day.
Yeah.
And this builds my perfect transition. Thank you very much. We know that this is complex. There are complex environments, complex conditions, right? And especially inpatient environments. There's a lot of handoffs, changing acuity, nutrition adjustments, right? And Dr. Slovis, I'd like to start off with you on this one. Where do you see variability in insulin management creating the greatest downstream risk today? And how can systems design this better to better absorb that complexity safely?
I think the first thing that comes to mind, and probably the biggest to scale for me, is just documentation and making sure that all of the clinical data is available in the electronic health record. I think it's safe to say that all of us are using, a more advanced electronic health record today. So they have the capability of keeping this information recorded. But it's the process and the people that we need to make sure that we are encouraging to maintain the workflow in order to make sure the documentation is accurate. So, for instance, if there's variability in the process with timing of when finger sticks are done, when insulin is administered, if the insulin's administered and then not documented in an appropriate period of time, those are the gaps in process that lead to difficulties in transitions of care in subsequent points in the patient's care timeline. From the standpoint of administration, if it's not documented appropriately or timely, all the way up to the finger sticks and documentation of the patient's current glucose levels, that can snowball into poor control down the line.
And that I'm assuming creates risk for the whole organization, correct?
Correct.
Yeah. Dr. Shinester, same question for you here again. Where do you see that variability in insulin management create the greatest downstream risk for organizations?
Well, I think clearly handoffs have a lot to do with it, especially when you look at the hospital environment with hospitalists and they're turning over every several days, or patients are often getting transferred from unit to unit because of acuity, bed availability, and often again the focus on insulin dosing may be lost a bit, and it's important for these patients to really have their insulin dosing updated on a regular basis based on what happened the day before. And just leaving the patient on a static protocol as they're moving from different care venues, different providers, can be a real recipe for disaster. I think another issue that was mentioned but needs to be highlighted a bit more is around nursing education, nursing knowledge of diabetes management. We hear frequently an alarm in the nurse's voice when they hear a large dose of basal insulin that's been ordered. They view that almost in the same light as a large dose of short-acting insulin, and it's completely different. And what happens is often those large basal doses are held, and then hyperglycemia ensues. So really working on a good uniform knowledge across all the nursing personnel is a really important aspect.
Yeah, again, it adds another layer, which is the educational perspective and the change
Yeah.
management and the leadership perspective on this from a system side of things. Dr. Marshall, you've touched on the fact that you're trying to get to your goal. You're optimizing processes across the board, across the organization. For you specifically, I'd love to touch on the system aspect of this, right? How can systems be designed to better absorb some of this complexity safely that we've touched on?
That's a great question. I think that as we look at patients that come to us, and there are a lot of different areas that make it more and more complex as we go through. So, Dr. Chidester mentioned it, as so did Dr. Paul, in terms of patients and variations in timing and testing of glucose. And then the other thing that we're looking at, or at least we should be looking at, is timing and of meals and the intake amount, which is often not documented well. So we have diabetics on medication in the hospital who are eating or not eating, and we're really not taking that into account a lot of times as to whether or not they're going to be hyper or hypoglycemia. And I think as they change acuity and go from one level of care to another, from the ED to the inpatient to the ICU, those are complex areas that are ripe for us to miss an opportunity to prevent an event with our patients. And so moving forward, I think that how we identify solutions to those problems is going to help us in the long run, and help the patient too, right? Because it will prevent these events.
A lot of reporting. And again, it comes back to reporting and then also the data aspect of this data analytics to be able to say, okay, what does it actually do? How's that data processing, which is really, really key. Dr. Paul, would love to get your perspective on this as well here in terms of, again, some of these complexities and how to create safe processes within this context.
Yeah. I think another area for us is really the decision support for the dosing. So we talked about, the training for the multidisciplinary teams. I think that's really important. And, we've already highlighted the transition of care. I think that's another area where we have some opportunity from inpatient to outpatient and within the inpatient setting from different levels of care. So those are two areas of focus for me.
Yeah. I want to come back to something that Dr. Shidester mentioned here not long ago, which is again the nursing aspect of this, the workforce piece of this, which is really, really crucial. How does inconsistent glycemic management affect workload, right? And what role should system design play in reducing some of this cognitive burden while still supporting clinical judgment all the way through? Dr. Paul, I saw you nodding your head there specifically on this piece because it's so important for clinicians to be able to provide good patient care. How are you seeing this?
Yeah, I think it's such a timely question. I think the alert fatigue is really is a real thing, and I think that whatever systems we implement, it should be used to enable the frontline teams and not just add complexity to their workload. So I think that's the real dilemma that we've got to be able to solve. That by itself, technology is not the solution, but how it improves the workflow and almost becomes invisible in the background is really the challenge in front of us.
Yeah. Dr. Slovis, the alert fatigue, I'm assuming is something that you're seeing as well. How are you viewing this when it comes to the workforce element and the nursing piece of this?
Yeah, I mean, obviously, being an informaticist, very focused on alert fatigue, and we have a very robust decision support group that assesses every single OPA and every other element of decision support at our organization, and we try very hard to minimize that impact to make it as useful and accurate as possible. I think from the standpoint of the workforce, and when we talk about workforce, we're really talking about nursing because they're the frontline clinicians when it comes to managing diabetes with, excuse me, not just diabetes, but glycemic control at the bedside. Um, you know, it, one consequence of this focus on this becomes that our nurses are asked to increase their cognitive burden throughout the entire process, whether it be through alerts or through education or through process improvement. And I think we have to be really conscious of that. They are now not only the ones that are actively caring for the patient at the bedside, but being asked to be an error catching layer of the entire process. And that can lead to fulfillment, if the processes are developed to allow for our nursing colleagues to really leverage their skills and manage their patients appropriately, or it can push them to try to find workarounds if the workflow is poorly designed. And I'm not suggesting that our nurses are attempting to do this. It's a natural human response to a bad workflow. You try to get your job done, and in poorly designed processes, it's second nature to try to find an efficient way to do something, perhaps at the expense of the overall goal, which is tight glycemic control. So workflow design is critical for maintaining the workforce that's going to manage the diabetic patients and the glycemic patients in the hospital.
So this is also a risk factor here as well. It contributes if those workflows are not properly set up. Does that create risk as well from a nursing perspective?
It creates risk for the quality of care provided to the patient. I don't want to make it sound like the nurses individually are increasing risk. They're trying to do their job and do it appropriately. It's not the individual bedside nurse's job to create an appropriate workflow for management of glucose in the hospital. That's the job of medical and operational leadership. But our nurses have to do their job and get their work done. If we don't provide convenient and facile workflows, they are going to try to get their job done no matter what. So one of two things has to happen. They either have to have, if it is a intuitive workflow that makes sense, then it's not a hard ask. If it's a workflow that is atypical from their standards, then there has to be a very justifiable reason why we're asking them to do something different from what they perceive to be the most facile way of doing something, and show them the meaningful outcomes that justify a change in their process or a process that is perceived to be more difficult.
Yeah. Dr. Shadester, looking at this again from a system perspective, right? What role does then system design play in reducing that cognitive burden that we've just touched on, while still, again, empowering nurses, empowering the clinical bedside piece?
I think the use of decision support tools within a system really helps to minimize the cognitive burden. It doesn't necessarily mean that because you're using a decision support tool that you're going to be flooding the nurse with a lot of advisories, but instead you would want the decision support to help guide them, to have them feel more confident in the dosing that they are administering, to give them reminders of any changes in the patient's condition that can be entered into an application to then modify the dose that the patient's receiving. It can provide explanations to the nurse as to why the dose is such as what it is, so the nurse doesn't look at a dose that's recommended and say, oh, I need to call the provider for this, which is going to be more work on both the provider and the nursing standpoint. But using a decision support tool across a system that eases the workload and also provides more confidence to the nurse, so that as they become more confident, then that cognitive burden is decreased. So I think those are important things to take into account. And then it's also important to remember that treating an episode of hypoglycemia or severe hyperglycemia increases their workload. So using tools to prevent that dysglycemia is in fact going to make their workload easier, and actually they're going to have likely happier patients and family members. So that's also going to reduce their workload.
Yeah. Dr. Marshall, as you're moving towards your goal, just to hit on that again, are you having those conversations with your workforce? What are those conversations that you're having again to talk a little bit about this again, the dangers of inconsistent glycemic management? Again, how does it affect workload? And are you having those conversations?
Yes, we're having those conversations. And one of the things that we talk about, we're not to put everything on nurses, but other nursing staffs like patient care technicians, that are doing the actual glucose monitoring, and giving them more education and um, more the ability to speak up when something is going down or their sugars are going up, and really making sure that they're part of the healthcare team. And I think that that's one of the things that we've been working toward, is making sure that the team is functioning as a team, and it's not just the nurses, right? So it's got to be all of us together that are working to help prevent these episodes.
Now, one of the crucial pieces is that, again, you all work towards patient care. You want the patient to get better, right? The patient eventually moves across a unit. Eventually, transitions out of the hospital. I'd love to know how health systems should think about that continuity and consistency of insulin management across the care continuum, really. And what are some of the capabilities that are essential to support that safely, again, when that patient eventually leaves your care? Dr. Paul, we'll start off with you on this one.
Yeah, definitely a really important point. Those transitions of care, transitioning from the inpatient setting back to home, and ensuring that we've got a good system in place to be able to track the data. So I know that there's a lot of interest in remote monitoring. So would love to hear from our other panelists, what their systems are doing and where we think the future is with that transition of care and remote monitoring.
Are you currently utilizing remote monitoring?
We do in some situations. That's not universally implemented, but yes, we're definitely exploring it.
Yeah. Dr. Slovis, again, same question for you as we talk about that continuity specifically for the patient. What's important and what are some of those capabilities that systems really should pay attention to?
I personally think this is a really interesting opportunity for improvement. And I will say that we have not solved this problem, but we are beginning the process of investigating how we can solve this problem. You can kind of break it down into a couple of different categories because there's those patients that come in and it's the pathology of their presentation why they do not have euglycemia in the hospital. And usually those patients are able to be discharged effectively once their pathology is resolved. But then there's a group of patients where they come in with already some usually diabetes, some issue with their glucose maintenance as an outpatient, and many are controlled and transition in the hospital and then transition back to their outpatient maintenance. But there's a large population that are just poorly controlled as outpatients, and it's not due to any specific factor, whether it be the individual or the care, et cetera. It's due to a multiple different socioeconomic impacting factors. That's the patient population I find really intriguing because we correct them in the hospital with close maintenance, and then traditionally they were sent back home on their home regimen. How can we impact that group? And we're exploring a number of different ways. We want to try to figure out how we can leverage e-consults so that we can get, when appropriate, endocrinology involved. An endocrinologist does not need to be involved in every diabetic patient's care, but there are certainly unique opportunities to involve our endocrine team. But there are certain situations where they do not have to see them in person. We have potentially weeks worth of inpatient data, and they can make inferred decisions on that patient's outpatient glycemic control needs based on their inpatient information. So how can we leverage that process? And then how can we leverage our high-risk clinics to get those patients in within a very short period of time after discharge to make sure that whatever they're discharged on is controlling them effectively, maintaining their euglycemia, making sure they're not becoming hypoglycemic at home, and also that they're adhering to that regimen. Patients, generally speaking, are surprised to learn that their home regimen was not appropriate. It's what I've been on for years. Well, sometimes, your needs change. How can we educate patients so that they can better understand what they're going to need as an outpatient when leaving the hospital so that we can reduce their cardiovascular risk, their stroke risk, and their readmission risk for glycemic issues?
Yeah. Dr. Marshall, are you doing similar things again? How are you making sure that patients are there when it comes to that continuity and consistency piece? And again, what are some of the things that you think systems should think about in promoting this and supporting this for patients?
Um, so I think that we have been consistent in healthcare and with this issue for a long time. As many of you may or may not know, sliding scale insulin monitoring began in 1934 for inpatients before all of us were born. And we're still using it. We're using it in the hospital, and then we're sending patients home on it, right? We're telling patients to go home, check your sugar. If it's 200, give yourself this much. If it's 400, give yourself this much. And also in the hospital, we're controlling their diet, right? We're giving them a diabetic diet, but then when we send them home, they go back to whatever they were eating before. So I don't know that, while that's challenging, especially depending upon your community, I think we could do a much better job in that. The other thing I think that we can help with all of these transitions and transition to home care is really improving our use of continuous glucose monitoring. While it's not FDA approved for in-hospital use, it's been around since 1999. And so 25 years later, I mean, there's research and there's studies that are out there, but we're not utilizing technology, I think, to the best that we can for our patients with diabetes in terms of managing their hyper and hypoglycemic episodes. So we have work to do.
Dr. Shadester, I saw you nod your head there, especially on the continuous monitoring piece, as Dr. Marshall just outlined. Again, would love to get your perspective on this as well, specifically on the conversations that you're having around this when it comes to supporting that continuity and consistency for patients.
Sure. So yeah, the continuous glucose monitoring is a key factor to consider when discharging patients. Yes, it's a bit of an obstacle that a lot of hospitals will not use it in the inpatient setting, although some places will use it if they were on it when they were admitted. But a new diabetic or a diabetic that came in poorly controlled, one of the best things you can do for them at the time of discharge is to put them on a CGM if they are of the fortitude to use that. And then just a little plug for Glooko, hooking them up with the Glooko app that will all that CGM data will be downloaded into the Glooko app that then can be uploaded back to the clinician is a key factor that can help monitor their control and identify patients that are falling out of control. And then just the other point to make around transitions of care. I used to lead a readmissions reduction team back when I was at Centera Healthcare, and there was a real feeling within the executive leadership that there must be one thing that you could do for every patient that would prevent readmission. Transitions of care can be very expensive, and it really takes an assessment of those patients. Who are the ones that are at risk to get into trouble? Is this patient that's being discharged, or is this a readmission for them already? Were they in the hospital, 6 weeks ago? Or do they have other issues that need to be addressed when they're discharged? Because not everybody needs the same cookie cutter approach. Some will need very little. Some will need an awful lot of hand holding. Some will need, medication assistance. But really taking a look at those patients and assessing what could go wrong with that patient when they leave the hospital and sort of give them a backstop for those issues.
But you mentioned two very important things here, which is it needs to be easy for the patient. The patient needs to be able to have a usability of this. I love that you mentioned again apps, right? And sort of that consumer experience. It needs to be there for it to work. Patients will do it if it's easy for them, most likely, which is so crucial in this conversation specifically. As we're closing out here today, first off, thank you all so much for your insights. What an incredible conversation. As we're looking ahead to 2026, the rest of 2026, but certainly beyond as well, what does success for you look like in inpatient glycemic safety in that CMS reporting world that we're now in? And what are some of those foundational changes that need to be in place for organizations to get there right now? Dr. Paul, I'll start off with you.
Thanks so much. As I look to the future, definitely agree on the concept of continuous glucose monitoring in the inpatient setting. I think that would be really valuable for certain patients. We've already talked about predictive analytics, so anticipating hyperglycemia events before they occur. More automation and more decision support for our frontline teams. I think that would be really valuable as well. And we've touched on the technology across transitions of care, so that's another area of opportunity for us as well.
Yeah, there's certainly a lot happening in 2026 when it comes to that. I feel like we'll have another conversation at the end of the year with a lot more technology, hopefully. Dr. Slovis, same question for you. Again, what does success look like for this in this new world, and what are some of those changes that organizations need to make?
So I think, forgive me, I forget who cited it before, but discussing, catheter-associated infections and other quality measures. Having that same approach to glycemic events and thinking about them as preventable where historically they were concerning but not necessarily approached with the same vigor. The goal, we would love to say the goal is zero, but in a realistic world, the goal is never going to be zero. But the goal is to prevent preventable events and be able to explain and learn from the rare unpreventable events. And that I think is, if that approach is taken with this, like with many of the other quality measures that we, try so hard to improve upon, that's how we're going to see effective change with this measure. I agree that that technology can play a critical role in all of this. I think that the major thing is going to be just reshaping the approach and the perspective.
Which is often the hardest part because
Correct.
we talk about the leadership aspect and the change management piece for a lot of organizations. Dr. Marshall, I know the goal for you isn't zero, it's 1.6, as you've highlighted earlier. Again, what are you seeing? How are you? First off, again, you're getting there, but how should health systems really look at this as they, move through 2026? What does success look like for organizations now, today? And what are some of those changes that leadership and organizations need to be aware of?
I think Dr. Paul mentioned, using prediction and predictive analytics. I think that's going to be critical. I think all of our EHRs are advanced at this point. And so how can we use that technology to provide a summary or a graph for a provider so they don't have to go in and look back at all the different finger stick glucoses over time, right? They can look at it as a function over time and make it easier for the providers. And I want providers, nurses, doctors to look at that data, and even if we don't have a predictive analytic tool, to be able to know from intuition or from experience that this patient's sugar is going to go up or this patient's sugar is going to go down. And I think that success is going to be some reduction in these events. Dr. Slovis mentioned learning from the unpreventable ones, which I think is also going to be key for us. Is the preventable ones, we kind of know how to prevent them, but the other ones we really don't. So how can we do that, in a thoughtful and thoughtful manner, I think is going to be what's going to give us success going forward.
Dr. Shadesser, first off, give you a chance to react to what you just heard from our panelists in terms of 2026 and beyond. But then again, same question for you from your perspective as well, right? What does a success look like? And what are some of those foundational changes you think organizations need to take?
Well, I think it might be a bit dreamy, but I think to really be successful would be to walk into a hospital and there's a sign in the lobby that says it's been 18 days since we've had a severe hypoglycemic event. I mean, we take a similar thing with other safety events in our hospital system back in the past. So success would be that it is completely transparent. Everyone is aware of what's going on. They can see the hot spots. They can dive into them and really clean things up. They can see that there was an event of hyper or hypoglycemia. What caused it? What are we going to do next time to prevent it? I think is a clear, obvious sign of success. So just complete transparency on glycemic control is really, I think, where we would really love to be. And I think our patients would be in a much better place. A lot of tools that can be used for that, as we've talked about today, and to see those tools implemented would be excellent as well.
Just as a really quick follow-up to this, is technology the critical enabler for this now in 2026 and again next year too, beyond?
I mean, technology is a tool to be using, but it can't be using alone. You have to be looking at your processes as well and how you're evaluating those processes. So technology is a great advocate, but it can't go alone.
Yeah, it comes back to what Dr. Slovis was saying. It's a mindset change, it's a leadership
Yep.
change, it's a perspective change, as you've just highlighted as well. I want to thank you all so much for being here. What a great conversation. I want to thank you all so much for your insights, for taking some time for us today. I want to thank our audience for listening to us, for being here as well. And I want to certainly thank Glooko for bringing us together for this fantastic opportunity, for sponsoring today's webinar and this conversation. Again, thank you for being here. Thank you for taking the time. And I hope you have a great rest of your day. Thank you so much.
Thank you all.
Thank
Thank
you.
you very
Thank
much.
you.
Take care.